And so what I'm going to talk about is home sleep testing and telemedicine and dental sleep medicine. And the reason why I started this process is, for me, things are very easy. I'm in a medical office. It's my office. I'm a licensed dentist. I'm a licensed physician. If a patient comes to me and I screen them for obstructive sleep apnea, it's easy. I order a sleep test. I interpret the sleep test, and I do whatever treatment is appropriate. But most of you in this room have an entirely different workflow. You know about the workflow, and some of you have navigated this very successfully, and you've built relationships with physicians, and some of you have struggled with it. I think some of you that have dental sleep medicine practice only have really figured out how to do this, and that's why you're successful. But a lot of us struggle, and particularly the new people who get involved in dental sleep medicine. They go to a course, they get excited, they want to come home and treat patients, and then the reality of what you have to do is too much, and they give up, right? Everybody's been in that situation. And so why is it so hard? It's hard because you have to deal with dentists, physicians, back and forth, different types of specialties. You know, I kind of wear two hats because it's not that I refer to myself. Everything that most of you go through, I don't have to go through it all. I'm very fortunate that way. Okay, now, I'm going to disclose that I'm the medical director of ProSomnus and Better Night of dental sleep medicine. And I'm not here to promote the company, to tell you to try and use ProSomnus as your only appliance, or to use Better Night as a telemedicine platform. But, you know, I'm involved with these companies, and I'm very upfront about that. What does a chief medical officer do for a medical device company? So my role really is to increase physician acceptance of oral appliance therapy, period. How do I do that? By lectures, by attending meetings, by understanding the literature. And the whole idea behind what I do is to make it easier for you to treat your patients, and also to increase the physician acceptance of oral appliances. Here is basically what we all know. This is the entire system, and this is what's wrong with our system. Too complicated, right? These are all the steps: the best practice protocol, assessment by sleep physician, the HST or PSG, the assessment, the informed consent, all these things. It takes too long. Right? I mean, that's really what one of the problems is. Care is complicated and burdensome. Treatment takes too long. Compliance with CPAP. Has it improved since 1981? No, it has not improved at all. Machines have been made quieter, they're smaller, they're easier to clean. Compliance has not changed. I put people on CPAP all the time. I'm a sleep physician. I also put people on oral appliances. But the reality is that oral appliances have been available since the 1980s, yet dentists in some states are unable to diagnose OSA and order an HST in most states, and they must network with physicians for referrals. This makes it hard. And so it's all about change, how you're going to change your mindset and what you're going to do. I love this slide because these are 4 companies that were really benchmark companies in our society. Big Blue, Kodak, Sears, GE. Where are these companies now? Kodak is barely surviving. It's on life support. IBM, if you bought IBM stock 25 years ago and you have it now, you have the same amount of money that you put in IBM. They've gone nowheres, okay? They're a huge company. They're struggling. Why are they struggling? Because they really didn't implement change as what they needed to do. GE, Sears doesn't exist. So why don't we change? Why don't we change your mindset? Well, what we're doing is working. There's a financial disincentive to change, inability to grasp the challenges, fear that changes will not be effective. You know, it's interesting. If anybody here uses alginate and stone models, don't raise your hand. But you know something? You should add. Why would you be doing that in this day and age? Okay? Well, because it always worked. I'm comfortable with it. Well, that's a terrible reason. okay? It really, truly is. So then you go to PVS, works for me. I don't need a digital scanner. No, you don't. But guess what? You should be using a digital scanner, okay? Because things change. And can you do oral appliances with alginate and stone models? Of course you can. That's not the point. The point is we got to change everything as we go on in life. And what happened? All of a sudden we had this pandemic, right? Everybody's heard of it, I think, COVID-19. So things were shut down. And all of a sudden we had to adapt and change. All I know is I never watched Netflix in my life until COVID came by, you know, because I was never home. You know, I was always working. Then all of a sudden I'm home at 3 o'clock. The point is in this pandemic, we all had to adapt and change, okay? Some of us were able to change and implement that change easier, and some were not. The reality is some offices were open, some were not. I never closed my office, ever. It was never closed during COVID. Now, I didn't have the same patient volume. I followed the protocols, and we stayed open. In dentistry in some states, you were mandated to close. There's nothing you could do about it. So, you know, and then their primary care offices were for about a year, they weren't seeing patients. And I couldn't understand it because my thinking is when you're sick, you go to a doctor. But now if you're sick, you don't go to a doctor because you're sick and they don't want to see you. That's what happened in COVID, you know? You had heart disease, chest pain. No, we can't see you. It's COVID. Aren't you a cardiologist? Yeah, but, you know, there's COVID. So we struggled, okay, to change. Elective surgeries were stopped, and, you know, we had time on our hand. Some people were reading journal articles. Some people were spending time with their family, whatever. But we had to change our mindset. So let's just look at what happened during the pandemic. And, you know, this is an old slide, but I have it here it's really old now because it's 2.5 years ago. But sleep labs closed, and yet we had HSTs. But then people didn't want to go to a sleep lab because they didn't want to touch the HST. People didn't want to touch their groceries, right? They were afraid. We didn't know, okay? But the point is at that time, HSTs, I got to tell you something. I've been practicing sleep medicine for about 15 years now, okay? Medical sleep medicine. There are very few indications for a PSG nowadays, okay? There are some, okay? The reality is people in sleep medicine fought the use of HSTs. Why did they fight part of it was they didn't want to change, a financial disincentive to change, and so the bottom line is PSGs were not being utilized. I'll tell you why our country is in trouble financially, just my own anecdote. Medicare, the private insurance companies don't want to pay for a PSG. You know what most of the business is in sleep labs? Medicare. Does that make any sense? No, it doesn't make any sense. The point is that change gets implemented slowly. And you got to have a really good reason to get a in-lab study. There are reasons. People have comorbidities, COPD, obesity, hypoventilation syndrome. You think they may have narcolepsy or idiopathic hypersomnia. Sure, you'll get a PSG. But HST, in some ways, should be the new gold standard. We always say the PSG is the gold standard and CPAP is the gold standard. But what I would argue now is HST is kind of the test of choice unless there's a reason to not have an HST. Okay? So what's the problem? We have a medical disorder and the majority of the people should be treated with an oral appliance therapy. Sleep physicians continue to preach the gold standard is CPAP. Okay? I love this. I hate this term. I can't stand the term. And the reason why I can't stand the term, if the gold standard is not used in 70% of the people, how is it a gold standard? If you had hypertension or diabetes, and you took your hypertension medication, and 7 out of 10 people couldn't tolerate it because of side effects, would you call it a gold standard? No, and every paper you read on obstructive sleep apnea in the introduction talks about the gold standard of CPAP. We know because of phenotypes. We know because it's a complex disease that the notion of a gold standard is just a term that shouldn't even be in the literature, but it's always referred to, right? Gold standard CPAP, gold standard PSG. So now we have this situation where dentists can't diagnose OSA or order an HST without being liable for practicing without the scope of their practice. And you know, this has been something that is argued about. Everybody knows this slide. If you don't know this slide and you don't understand this slide, it's Sestuli's paper about efficacy versus effectiveness. This is what you got to tell your sleep physicians. You should tell them this all the time. Efficacy is how something works in the ideal world. Effectiveness, how it works in the real world. So I would argue that oral appliances, for the majority of the people, may be equally as effective. And a lot of physicians don't understand that. I happen to be a physician that understands it. And what do physicians say? We're going to talk about telemedicine. I don't want to disappoint you. I'm building the case for it right now, okay? So CPAP is a better treatment. Well, if you understand the concept of mean disease alleviation, is it really the better treatment? How do I know if, these are what physicians say. How do I know if the dentist is qualified to deliver an oral appliance? Efficacy studies often show residual events. If anybody, this kills me because there was a lecture today about surgical results and what was considered a surgical success. 50% reduction in AHI and AHI less than 20. That's surgical success. If your physician tells you with the oral appliance, hey, this person still has an AHI of 10 an hour or 8 an hour, and that's a failure, how can that be a failure if in surgery the criteria that I just mentioned is considered a good result? Think about it. Physicians have to be educated in that, okay? And then other things that, you know, you deal with. The dentist is not network, too expensive for my patients. Things about does not have a DME license, and you hear this all the time. Oral appliances don't work. My wife, who's usually right, but she wasn't that right. She married me. So she says, don't put a slide up like that. People are going to see this, and they're going to say that, you know, somebody's going to get this. They're going to publicize it. Here, you've said oral appliances don't work. You know why this slide is up there? Because every one of you have heard this in your offices. Somebody comes to you, and you're about to do an oral appliance on them, and the patient says, my physician said oral appliances don't work. Or what they say to you is, I was never given that option, right? Everybody's heard this, okay? So this is what I call the good, the bad, and the ugly of dental sleep medicine, okay? And this is going to set the stage, I hope, for telemedicine. So what is the good? We all know in 2017 that the ADA, everybody can have a copy of all these slides. I'm in the shared world of the economy. The House of Delegates approved an ADA policy statement addressing dentistry's role in sleep-related breathing disorder. So really what it means is that every dentist has the obligation, the responsibility, and it's your duty to screen a patient for obstructive sleep apnea. That's no different than screening for oral cancer, right? You have a new patient, you examine them, you look at their tongue, soft palate, uvula, tonsil region. You're a physician of the oral cavity, so you look at it, and what you're doing by screening patients is what your national organization has told you you should be doing as part of a routine exam, okay? And you know, you want to assess the risk as part of a comprehensive medical and dental history. And these are things that are all good. The literature supports the effectiveness of OAT. Compliance data shows that patients are highly compliant with their oral appliance. We do have compliance recording available. There's been challenges with that. We're trying to work them out. And healthcare outcomes, including quality of life, blood pressure reduction, sleepiness, etc., are similar with both treatment modalities. It's covered by most insurance companies. Medicare provides coverage. You all know the rules and regulations associated with that. The side effects, you know, I have to laugh about the side effect thing. And, you know, I was a dentist. My father was a dentist. I now practice as a physician. But I don't get hung up on side effects. I do things to people with surgery. I can really hurt them. They can die from something that I do. It doesn't happen that often, but you have complications. And I guess my point is, we as dentists, if there's some minor tooth movement, if there's TMJ problems, if there's some jaw things, we own it. It's not a big deal. It's really not a big deal. And I think, you know, I've been treating temporomandibular joint problems for a career, for 40 years. And I would say to physicians who bring this up that it's not a big problem, because it isn't a big problem. If you have temporomandibular joint side effects, they can be managed appropriately, okay? So, what's the bad? Sleep physicians and primary care physicians control the flow of patients. In most states, the dentist can't order an HST, and some sleep physicians still believe that oral appliances don't work. I mean, I still hear this. It drives me crazy, you know, because a lot of times people will come in and they say, you know, my physician said, oh, you know, you can't have an oral appliance. It's not going to work. You know, the fact that that's said in this day and age in 2022 is absurd. To make that statement is just a very poor statement by a physician. And, you know, maybe they've had a bad experience with a few patients, but the reality is to say that oral appliances don't work is simply untrue. Okay, what about the ugly? The medical disease, the diagnosis must be made. The Stark laws are a big issue in the collaboration. There's a lot of different you know, models that have been used: a physician in a dentist's office, a dentist in a cardiology office or a sleep clinic, and they're now experts that, you know, healthcare law that really can set up these situations to, you know, take care of the issues. And the medical billing, there's companies that address this. So, you know, that's not a problem. And also, you know, looking at, you know, some of the things that we have to deal with, the ugly. I would say that an appliance to last 5 years, it's unfortunate that that's written that way. That's a long time for a device to be utilized to treat a chronic disease. But, you know, that's what's in the Medicare guidelines. Then we look at which is better treatment-wise, because, you know, when you work with physicians, there's physicians that what I call oral appliance friendly and physicians that are CPAP dominant. I just made up those terms. And, you know, you all have physicians that refer you patients. If they refer you patients a lot, they understand the role of oral appliances. They know that you're competent and they give you the referrals. And if you have ones that never give you referrals, well, maybe they're referring it to somebody else, or they just don't believe oral appliances work. But when you look at the efficacy and compliance profiles of CPAP and OAT, the superior CPAP efficacy may be offset by the greater oral appliance usage. And this is from Phillips' article in 2013. This is an interesting thing to see. This was done in Sleep Review, and these were the top reasons why physicians did not refer patients for OAT. One was, I wanted to try other strategies to get the patient CPAP adherent. The patient won't be able to afford an appliance. It might not be efficacious. Recording compliance was an issue. Side effects. I worry that dentists are acting outside the scope of practice in all or part when treating OSA. Patients disappear. Jeff talked about the communication with the physicians and sending them back. That's a great comment that he made, and I don't know a local dentist who I can trust with my patients. This is just from Sleep Review. It's not my opinion. It's what was written in an article in 2016. And, you know, this is the thing. Again, this is not about prosomnus, and I apologize that it's a prosomnus slide, but, you know, you need to show your physicians this. You know, somebody who's not treated, you treat them, and what kind of results you can get. And so what are the conclusions of physician acceptance, efficacy studies, patient comfort and compliance are marketing points, open discussion of side effects? I like to take anything that's a negative and turn it into a positive. Physician tells you about side effects. I'm glad you asked me that question because side effects isn't really an issue, and here's why. Okay? So you take that comment, you're kind of getting attacked a little bit, and you turn it around to make it positive. And, you know, insurance coverage, combination therapy, I'm sure a lot of you use that as well. You want to embrace the concerns that physicians have about OAT and the use and guide to further acceptance. So, and then to consider the telemedicine approach. So here's the thing, the way I look at it. You have the dentist, the physician, you have the patient, you want to get him treated, we have a complicated system, so how do we interject or introduce telemedicine to help? So here we're going back to what I mentioned before, a sleep physician that's CPAP dominant and one that's oral appliance friendly. So the CPAP dominant physician is going to preach CPAP as the gold standard, the gold standard, the gold standard. Stop saying that. It's not a gold standard, but they're going to say it, okay? Versus a patient-centric approach. What's the patient want, right? You know, recommends CPAP for mild to moderate cases of OSA, follows the AASM guidelines and recommendation for mild to moderate cases. You know, really what I think every sleep physician should do, in my humble opinion, is when a patient is tested, have a consultation with them. You have mild sleep apnea, you have moderate sleep apnea. Here are the options. What would you like to do? That's how you would like it to be seen. And instead, the default is kick them in with the gold standard, right? They're just put on, you've seen it, AHI of 6. Patient is not very symptomatic, and next thing you know, they're on CPAP, and they never even were recommended for an oral appliance, unfortunately. Okay, so here's a perfect example. 56-year-old person could not tolerate CPAP, told in no uncertain terms, you are not a candidate for OAT. Her AHI, 99 an hour, went to 2 an hour. You see the results there? I mean, this is a physician saying you are not a candidate for it. Everybody in this room has had cases like this. 100% I already know because my results aren't any better than anybody else in this room. They may be worse. So, telemedicine and oral appliance therapy. So, telemedicine is something you're hearing a lot about. There's things about it that are good. There are things about it that are not as good. You know, I think that the ability to examine a patient is limited. Of course, with a video camera, you can do a cursory examination. But, you know, a lot of what telemedicine does for sleep medicine is more like an interview to decide, is a person need a sleep study, okay? And that's very easy to do via telemedicine, okay? And so if you have a situation where you want to build a national network, it's going to be hard because of the licensing issues. What does the AASM say about telemedicine? They support efforts to expand telemedicine. They're committed to increasing the adoption of this technology to improve patient access. And in 2015, they came out with a position paper to detail the key features, standards, and process for a sleep specialist. Now, one of the things they've said is expansion of the sleep telemedicine into all aspects of sleep disorder was limited by technology resources, financial considerations, and willingness of physicians, patients, and healthcare organizations to accept it as an alternative to in-office care. The problem is you need to have a system that works, you need to be compensated for it. Nobody's going to do these consultations and never get paid for them, right? I mean, why would you do it? Okay, so we have to have a system that's efficient, that's reimbursable, and follows best practices protocol. So there's 4 key models of telemedicine services. There's what's called synchronous. I'm going to define these: asynchronous, remote patient monitoring, you're going to hear a lot more about it, and mobile health applications, or what's called mHealth. So what is synchronous telemedicine? You have delivery of a live interactive encounter in which patients and providers are separated by distance but interact in real time using video conferencing as its core technology. Provider performs interview with the patient. The diagnosis and treatment options are addressed through live video interaction between patient and provider. You know, I live in Syracuse, New York, and I have a home here in Scottsdale. I'm going to eventually be living here within the next year or so. And so yesterday, I played golf with Mark Murphy and John Carrillo, and they were over my house, and then Mark was doing a lecture for the Army, and then John was hanging around taking care of some business, and I had a couple of telemedicine consultations. And I said, you want to see how these are done while we're here? And so I did a couple of telemedicine consultations, and I think what was the funniest thing about it is that I don't know how many of you have had this situation, but it's a patient who has had Invisalign or adult orthodontics or is going to have Invisalign, and then they're going to have an OAT. And that subject comes up, how to handle that. So we're just talking about it. The very first patient that I have a consultation, I go through the consultation, and she says, oh, by the way, I was thinking about having Invisalign. Is this going to change anything you're going to do? It just was funny because we had just been talking about it, you know. And, you know, these issues can come up, of course. And then we have asynchronous. Asynchronous is non-real-time technology assisted exchange of structured information between a patient and provider with the intent to diagnose, treat, or triage. So you have a sleep medicine history. The sleep medicine specialist provides clinical advice via written or electronic report to the provider with a reasonable time frame to make clinical decisions. So what does that mean in English? It means that basically you have the data, the information on the person, you're reviewing it, and then you're preparing a report. Why is asynchronous a good modality? Because let me tell you something, when you do telemedicine live, you have to be available. You know, it's not, how many people have gotten an Uber and you say, well, this one's 3 minutes and the other one's 4 minutes. There's no way I'm waiting 4 minutes. I'm taking the one that's 3 minutes away, right? Because we're impatient. It's not really going to happen that way in telemedicine, where you can click on and in real time get a consultation at that second. I mean, come on. You would have to have physicians sitting around ready to do the telemedicine at any given time in different time zones. Will it get that way one day? I don't know. I mean, but, you know, the reality is the way that these things are done is a physician signs up for a time period, a block of time. Let's say that time is 1 to 4, okay? So they're usually 15-minute consultations. So what will happen is a person can go through the portal to schedule an appointment at that time. And will it ever become an Uber like that? I don't know. I mean, I don't think so. I think that's unreasonable. But people have expectations that they want things done instantly. And, you know, so asynchronous allows you to do the consultation, but not in a live format, okay? And that's reimbursable now by some insurance carriers. And then remote patient monitoring. Well, we already do it with CPAP, okay? We can get the data from downloading the chip. But really the ultimate goal in remote patient monitoring is to have a situation where you get continuous data on the feedback. Think about this if you have an oral appliance in, and I mean, we all know this. Let's say you do oral appliance therapy and you do an efficacy study, and the efficacy study shows good improvement, a successful result, then the person never wears the appliance again, right? How would you know? Well, you got a compliance chip. They're not perfect yet. You know, the 2 chips that are out there in the market, you know, there's been issues. I'm not criticizing them, but it's not perfect yet. It's not really where we want it to be. But how about if you could have data on an ongoing basis, moment to moment, on oxygenation, AHI, compliance, built into the appliance, and you could adjust it based on the data. That's where the field, I think, is going to go. Okay, and then there's the mobile health applications. You know, people say all the time, you know, I'm wearing my Apple Watch, I've got the Fitbit, I got this, what does it mean? It's data, but it's not the same as a true home sleep study, of course. Now let's look at the workforce issue. And the Center for Disease Control and Prevention estimate that 50 to 70 million people of the general adult population in the U.S. suffers from chronic disease related to sleep deficiency and sleep disorder. The general public is really aware of sleep and its importance. Why? One of it is because of the wearables. People are tracking this stuff all the time. You know, they come in, they tell you, they show you what they've got, and what does this mean? Okay? So people are aware, and employers are placing a greater value on sleep, and insurers, regulators, and legislatures recognize this importance. So I don't have data beyond 2018, but this is the number of sleep physicians that are board certified by the American Board of Medical Specialists, 6,035. Let's say it's 7,000 now. I don't know what it is, but the point is, with 50 to 70 million people, how you know, the numbers don't work. Okay? And so the current workforce is insufficient to meet the demands, so we need to leverage telemedicine capabilities, and that's how we're going to grow this. And it really allows sleep physicians to oversee things. And two studies were done at the VA and Kaiser Permanente, which are closed systems. They've shown dramatically reduced wait times from referral to diagnosis in the treatment of sleep-related breathing disorder, as well as increased adherence to treatment, despite an increase in the volume of sleep consults and sleep studies performed. You know, so the reality is let's say we start moving the bar, and we've got 85% of people undiagnosed with obstructive sleep apnea, and all of a sudden, into the funnel, so to speak, 50% of them enter. We're not going to be able to handle it. There's no way we can handle it. We don't have the workforce. So when you look at dental sleep medicine and telemedicine, dentists are uniquely positioned to take advantage of telemedicine. The ADA, as I mentioned, recommends for dentists to screen all patients for sleep-related breathing disorders. And then we have the barriers that exist. We have a lack of availability of sleep physicians in some areas, high cost, requirement for numerous visits and time involved, etc. Okay? Now, there's a couple companies. This is the thing about this field. We have home sleep testing companies, correct? You've used them. We have billing companies. You've used them. And we have different aspects that will help us. Do you think a home sleep testing company is a sound financial business long term? Who thinks it is? I can tell you it's not. The margins are too low, and for a company to just provide home sleep testing, it's not going to work long term. It isn't, okay? And then you have a telemedicine company. Telemedicine, you know, you have to have this network. You have to have a lot of providers. They have to be licensed. I am personally licensed in 40 states. I hold 40 medical licenses right now. Every 2 years, they have to be renewed. I would estimate that the license, the total fees involved to get 40 licenses was about $100,000, okay? And I can't tell you how many times I've taken the opioid course, the sex trafficking, child abuse, every 2 years. Ethics, you know, hopefully now I got good ethics because I've taken the ethics course in about every state that requires it. It's a daunting task, okay? My point is that companies that just do telemedicine, just do home sleep testing, are probably not going to survive long term. I have an MBA, you know, not that smart because I'm still working like a maniac at age 68, but I do have a business degree. And I will say right here on this podium, these companies will not survive doing just HST and telemedicine. There's just, the margins are too low. It's not a sustainable business model. What drives these companies? The DME component, durable medical equipment. There's revenue to be generated from CPAP and the renewables and the supplies and things like that. So, you know, we're in this, there's 1 billion people with obstructive sleep apnea, 85% undiagnosed. So the opportunity is huge. So people are coming out of the woodwork to start companies in the various aspects of things that will help you. But the reality is it's going to be very challenging from an economic standpoint to make it sustainable. That's just the math of, if your volume, if you're losing money on what you do, you're not going to make it up on volume. You don't need an MBA to figure that out, okay? So there's a couple of companies in this business that I'm just going to mention that kind of cater to dentists. Better Night Sleep Solutions, Blue Sleep, SleepMed RX. Blue Sleep is run by a colleague of mine, Dr. Jordan Stern, and that's not really a company that is geared towards helping dentists per se. But he has a model where he does telemedicine, home sleep testing, and he himself provides the oral appliance. And the Better Night Sleep Solutions company that I'm involved with has a DME component to it, and the SleepMed RX company does not have a DME component to it. So it's just, I'd like everybody to just understand the complexity of this problem. So what's the workflow look like? Well, the dentist or dental office screens the patient, positive screening, schedule telemedicine consultation at checkout. You get a consultation via HIPAA-compliant web-based platform. Now, you can use different HST devices. There's many of them out there. In this example, it's the WatchPad 1. I don't work for the company. I don't promote the company. I use their product a lot because it works well for me, and it's single-use disposable. And they happen to come out with it in November. And when were the first COVID cases? 2 months later or whatever in the United States. So then the telemedicine consultation to discuss the results with the patients. And you've all seen this. I don't really have to go through here. There's a video as well. But here's the workflow. Standard workflow, cumbersome. Telemedicine, efficient. Multiple visits versus minimal. Lengthy versus streamlined. Costly, wastes resources. Economical, preserves resources. One's patient-centric, one and dentist-centric, and the other's physician-centric. So the standard workflow, relatively high chance of failure. Telemedicine workflow, high chance of success. And patient satisfaction, that's what it all comes down to. Your patients come in, they're busy, and they want to get to the end point sooner than later. How do they get to the end point sooner than later? You remove the barriers, And, I think that there are various ways that there's people like my friend Ken Smith has a sleep physician in his office. He has a great model, okay? And it streamlines things. And I think that the standard workflow is one of the reasons why things are taking so much time. So from the dentist perspective, the referral process is efficient, may be scheduled at checkout, and using telemedicine, collaborating with physicians allows accurate diagnosis. The physician's making the diagnosis. You think about it, let's say you're a general dentist and you screen a patient, okay? What's likely to happen? So you send the patient to the sleep physician. They wait 4 to 6 weeks to get an appointment, and then, they go down that path. It takes too long. From a physician's perspective, it allows them to expand their reach, and it can be done in a clinical setting like a dental office. A lot of this has evolved. One of the things that the COVID and the CARES Act did is it helped boost telemedicine through Medicare and then the private insurance carriers. And, my friend Dennis Bailey, who I think is retired now, has always made a big thing in his lectures that, you don't screen with a home sleep test. We know that, You screen the patient with your screening tools. If they screen positive, you do a home sleep study, okay? And so what really happens, so there's the dentist perspective, the physician's perspective, and then the patient perspective. And it reduces the time traveling back and forth to various sleep centers, less expensive. And, what do we want? We want to empower the dentist, patient-centric platform, okay? And when I started my own telemedicine company, which I eventually, I didn't have the bandwidth. I didn't have the ability and the financing to do this on my own, so I joined a company, Better Night, and then they proceeded to get me the licenses. But I saw a need for this because I feel the struggle of all my colleagues. Now, do I have a few more minutes, or, you know? I mean, I know it's a long day. If anybody wants to leave, it's not going to hurt my feelings. You can leave. But I want to go over some of this stuff in a company, Better Night. This was, and again, it's not to promote them specifically. I want you to see how it works, okay? And this was Sleep Review, a webinar that was done, that we did for Sleep Review magazine, okay? Better Night is a company that's been around for over 25 years, started with home sleep testing. Okay, and what they did is, this is the numbers, 30,000 people treated annually. Average patient satisfaction score is extremely high. Now, when I first met with them and they showed me the long-term adherence, I said, I don't believe it. I said, there's just no way. You're twice the industry standard. Because if you look at what is the compliance long-term of CPAP? 3 out of 10 people stick with it long term. Those are the numbers. It's not changed in 41 years. Colin Sullivan, I'm not knocking CPAP. He's one of the, first paper in the Lancet Journal in 1981 that CPAP is the gold standard. I don't know if you know this, but he has said to a friend of mine who's a dentist in Long Island, does a lot of sleep dentistry. He said, CPAP's not really that great of a treatment. Okay, he said it, the guy that invented it. He has sleep apnea. He wears an oral appliance. He does. But it led to the growth of 2 gigantic companies, Philips Respironics and ResMed, and we know the challenges now that's happening with Philips. But it's kind of interesting, that the guy who invented CPAP is saying it's not that good of a treatment. I don't think he broadcast it. He just said it to one of my friends. So, sleep care management is changing. I had the slides on change. Why do I talk about change? The world is changing. You can either embrace the change or you can fight it, okay? So if you embrace the change, you do the right things to have a successful practice with time. If you don't embrace the changes, you get left behind. You do, okay? And it's happened in every industry that we're in. And that's why I showed those companies, because the lesson to be learned is, as the world changes around you, you have to adapt to it, And I feel strongly that most dentists can treat the majority of their patients without ever seeing a sleep physician except for a virtual visit, okay? And I truly believe that. You just haven't had a vehicle to do that. Now, a lot of you that have mature dental sleep medicine practices only, that's a different animal, because you interact with sleep physicians a lot and you don't want to hurt their feelings or insult them, or, I got to tell you, and I don't mean this in a disrespectful way, truly, please take this in the right context. Do you think the physicians really care about the dentist? Seriously, I don't mean that in a mean way. We're, as dentists, so I have 2 hats. I happen to be a Yankee fan, but if I had 2 hats, it would be I'm a Yankee and a Red Sox, right? They hate each other. Okay, so I'm a dentist and a physician. The reality is, we as dentists, now I'm talking from my dental hat, we're so worried about insulting the physicians, but the physicians are not sitting around, geez, I hope this dentist doesn't like me. Come on, that's true, okay? So what can we do? If you have a general dentistry practice, you can start screening every patient, okay? You have to, and there's courses that go over this. It can't be asymmetric screening. You have to screen every person, because you cannot look at a person and determine if they have sleep apnea. Why do we have screening? Because the screening asks questions to increase the probability that the person has obstructive sleep apnea, and then you order the appropriate test, right? So, we've run numbers before. If you screen all your patients, what you can generate in a mature general dentistry practice is a very significant number of people who are going to be positive for OSA. So you can go down the conventional pathway and send them to a sleep physician and hope they come back. Or you can utilize telemedicine, get a board-certified sleep physician to diagnose them, get an HST, and then what that company must do is they must send them back to you. Because if they don't, you're never going to use that company again, right? I mean, if you've had a patient that you screened as mild to moderate obstructive sleep apnea and they put them on CPAP, you're not going to be happy because you utilize the service to help treat your own patients. And this is the way it can be done now. And, you know, it's interesting about telemedicine. Telemedicine, there's certain things that you can do. You can't really truly examine a patient. But can you, when you do the oral appliance, you're going to examine the patient prior to doing the oral appliance. The physician is determining, does the person need a sleep study? Once they have the sleep study, what does the sleep study show? And once you get the information, you make the appropriate recommendation, okay? So, you know, of course, COVID has accelerated this process, and the system that Better Night has, and I'm not really here to promote Better Night. I'm using it as an example because there's really only 2 companies that do this completely, and, you know, I'm forthright with that, I hope. Patients can enter at any point. They can enter just getting the sleep study, just getting the telemedicine, whatever they choose to do. And when I joined Better Night, they didn't have a dental arm, okay? And they wanted to build the dental arm. And the challenge in doing this on a national level is, again, the insurance contracts. We're not delivering the oral appliance. We're providing the mechanism so you can deliver the oral appliance. We're not going to do billing for you. What we're going to do is get your patients diagnosed, and then you treat them, okay? And, you know, sleep physicians, things were shut down, DME problems all over the board. And, you know, here's your standard conventional model. And here's the model when you add a telemedicine component to it. And then this was a physician we had who was a board-certified sleep physician neurologist in the San Diego area, and he converted his practice into 100% virtual. He closed his sleep lab, does everything with HST. There's still sleep labs available, so if in fact you need a study at a lab, you can get it, okay? And, you know, part of it is being in network with the various insurance companies. And then what Better Night has that's unique to them is they have their own proprietary software that allows them to monitor long-term the compliance. They have coaches. You know, one of the reasons why people fail CPAP, there's a couple of reasons that, you know, one is the follow-up stinks in a lot of the companies. A lot of these DME companies, they're terrible, you know, bad customer service, bad follow-up, they don't treat patients well, you know, people call for supplies, they wait for supplies. You can't run a company successfully like that. And what Clarity is a proprietary software that allows remote monitoring of CPAP. And then, you know, I joined them about 2.5 years ago. And, you know, here's your standard process here where you have patient screen, refer to specialist diagnostic tests, and patient often doesn't come back to the dentist. So now what we do is they are referred to Better Night, patient screens online, completes online consult, home sleep study, refers the patient back for oral appliance therapy. What we're providing is a vehicle for you to get your patient treated by you easier. That's our intention. And, you know, what's interesting about this is, and this is the way it should work. A patient walks in your office and you ought to be able to get to the finish line in 6 to 8 weeks. There is absolutely no reason why that can't happen, okay? And, you know, look, patient, it's Monday. Patient walks into your office. They get a telemedicine consult, let's say that week. They're not going to get it, you know, they walk out at 3:14 and they're not going to get a telemedicine consult at 3:20 that day. I mean, that's never happening, but say they get a consult that week, okay? They get an HST shipped to them. So within 2 weeks, hopefully, from the time they're in your office to the time the HST is done, you know, the patient also has to do it. Sometimes HSTs are sent to patients, I didn't really feel like doing it tonight. I was going out or, you know, whatever. They have to do it, of course. And then once it's done, I mean, when the test, one of the reasons why I like the WatchPad, one, but I'm sure it's available with other devices, is it's cloud-based. They turn it off, it uploads to the cloud, I get an email, and I can interpret it the next day and sign off it via DocuSign. So now, we have to arrange a consultation, and providing that you can get them in your office quickly. I mean, let's call it 3 months. There is no reason why from the time a patient walks in your office that you can't have them in an oral device in less than 3 months. Unless you're so busy you just can't see patients. So we got to streamline this approach. We want to make things easier for people. You make it easier, you have a better patient experience, and patients, everybody's got a friend. They're going to tell their friend, go to Dr. Jones, go to Dr. Smith. This was a good experience, and that's what we're striving to do. And I'm not saying that everything that we do or I do is seamless, because it's not. There's times when patients can't sign on. It's interesting. Do you think you can buy a computer now without a video? I don't think you can. But once I had somebody with a consultation, and it was an old computer, and they didn't have a webcam, and I couldn't believe it. You can't buy a computer now without, I don't even think they sell them with it. So the point is that we have the tools now to treat patients effectively. You should embrace telemedicine. In my opinion, you should embrace home sleep testing. And I'm not telling you to turn away from your sleep physicians. What I'm telling you is you want to get your patients treated. You want to choose the best pathway that can get them to the finish line the quickest, following best practices protocol. And that's what's out there today. And it's not about prosomnus or better night. And the technology and the experience is just going to get better and better with time. As we perfect it, we see what doesn't work. We try and get comments from our customers and do things better, because if a person has a bad experience, you go to a bad restaurant, have a bad meal, you're telling all your friends, right? Don't ever go to this restaurant. Hopefully none of you are going to that restaurant tonight. But that's really what I have to say, and thanks for listening to me, and if you have any questions.